There's gonna be a laptop on
It's
here,
just, I don't know, it's a little uneasy for me.
and your orders will be here. You'll have a copy of the protocol here and some blank paper and a calculator. And up here will be a compatibility chart and a protocol.
Okay.
Okay, so you'll come in, you'll pick your scale, say it's this one,
Yes.
and we'll tell you that you're gonna be administering Ansef, 1 gram in 100 milliliters to infuse over 45 minutes.
Can I get a piece of paper and do the math so I can get in the hang of that?
That's fine.
I have my computer and I'm going to, I'll look on the computer to see that doctor wants me to hang
So take it off, but don't crumple it.
Ansef,
Keep it off.
And what is this for?
That's.
The date?
an
that's-
IV
yeah, that's
piggyback,
your- That's your tab, that's your date and time.
and on the computer, the order will be what you said.
1 gram
Oh, but
in
it
100
can be-
milliliters
Is there
to
a white
infuse
tag
over
that
45
matches?
minutes.
Okay, we'll use that.
And the doctor's orders typically don't have the time to infuse, so we'll give it to you. But in the clinical setting, if it doesn't have it, then you go to, you right click over the med and then go to med details and it'll tell you how long to infuse it. Like it goes in over 30 minutes, 45 minutes, an hour.
Oh, so but you have to actively
You have to
seek
look
that
for
out
it, yeah.
yourself, okay. So,
That's good.
in that situation, in a real life setting, I would right click and go to med details and find that. You want us to show work? We calculated it. Okay.
What was it? Just curious.
Oh, 1 gram of Ansef in 100 mLs to go in over 45 minutes. Go in, infuse.
Over 45 minutes, so this is gonna be 133 milliliters per hour.
Good.
Is what I'm gonna program the Alaris to. So now that I know that, so I know my infusion rate and I know the drug that I have. And I'm going to look on the computer to see what was previously hung as the primary line, so I can see if my Ansef will be compatible with my primary solution, and I will be able to access that on the computer
No, because there's nothing ordered because it's a saline lock,
because it's a saline lock.
so there won't be a maintenance fluid order.
So it wouldn't be on the computer, so I would have to use Micromedics to see compatibility.
With what? What would you anticipate you'd be infusing it through?
Would I anticipate infusing the antibiotic through? Normal saline. Okay.
Right.
Okay, so it's compatible. So what I'm gonna do is I'm gonna go to the med.
What'd you do? What'd you forget? Went into the bedroom
Brought my computer.
before you gather your supplies.
What did I forget? What did I forget? This? Well,
You touch the door of the bedroom. Doors are full of germs. What do you need to do before you touch the med?
oh, when I enter the bedroom, hand
Sanitize.
sanitize.
Yes.
Okay. Didn't even think that. Okay. So I open the door, I come into the bedroom, I'm gonna hand sanitize, and I'm gonna gather my supplies. Because this is a heparin lock, I need 2 syringes. 2 syringes. Oh, never mind. I have my medicine and I have my, just forgot the name of it.
And do you need 2 syringes now?
Do I need 2 syringes now? No, but I like to have extra in case something happens that I don't foresee. But I'll need one prior to administration of the drug and afterwards for the port that I'm going to be connecting this to, so it doesn't hurt to have it.
Okay. But if you bring it in and put it down in the patient's room, you can't bring it back out. So keep it in your pocket,
I'll
the
have
extra
to,
one.
yeah, and I can't open that packaging, it has to be that packaging. Then I'll have, so maybe I should get the package. Yeah, and I'll have my cap, and then I'll have my 2 alcohol pads, and then I'm gonna need a labeler. I'm gonna be labeling this.
Oh, you got it.
Is that okay?
Mhm.
Okay.
Yeah.
So now that I have my supplies, I'm going to I'm in the med room. I didn't leave yet, and I'm gonna have to check on the MAR that it was Ansef antibiotic. I have Ansef here. It's 100. I brought that with me. It was 1 gram and 100 milliliters. I have 100 milliliters here. And I'm gonna check the medication that it's clear. I'm gonna check the expiration date, which is November 2019. And I have checked that Ancef and normal saline, which is already infusing, is compatible, so this is okay to use. And then it's for Jane Tripp, the right patient, the right medication. I'm supposed to be infusing this now.
How do you know it's due? How do you know you have the right time?
How do I know I have the right time? I have a watch that tells me, and it's on the computer.
And it says it's due at 2:30, but what else do you want to always check?
I want to check when the previous medication had been administered.
Okay.
Um,
So it was 8 hours ago.
It was 8 hours ago, and so that was 6:30 in the morning. It's 2:30 now, and I have all of my supplies. I think I'm good to go.
What else do you want to check?
I want to check.
So you have the right patient, the right med, the right dose, the right time.
Where I'm administering this, what part of the body, if it's a central line or if it's a PIC line. I'm missing something.
Will there be any difference? PIC line and central line?
I'm gonna have to flush either, but I have to check on my computer to see where this heparin lock is, and the heparin lock is gonna be in the right arm, antecubital.
Nope, CBC. It's in the chest.
Okay, I'm only doing that. So it's gonna be a central line flush for my route. So medication, client documentation, time, drug, and route.
And how do you know you have the right dose for this patient?
I have it. I know I have the right dose because I have 100 milliliters here, and on my MAR it says I'm going to infuse 1 gram of Ancef in 100 milliliters, and I have 100 milliliters here.
So you have 1 gram in 100 milliliters. But how do you know that's a safe dosage for your patient? Because the doctor ordered it?
I know that it is a safe dosage because I will I contact pharmacy to make sure this is a correct amount.
And the pharma will say, why are you asking?
Why am I asking? Because, well, I don't know the answer to this one, so
Anybody?
flat out.
Renal dosing, you want to check for that. You can probably look at.
Oh, I have to know the patient's condition.
Yep.
Like
So
the
patient's being
GFR.
treated for a UTI.
Okay, well the GFR has to be greater than 60 to give an antibiotic.
Well, when it's less than 60, you need to check if there's any dose adjustment. Not all antibiotics are renal dose adjusted. Some are liver, some are obesity, weight, some are not at all. But you just want to check the renal if there's any dosaging changes, if they have renal or liver compromised.
I have to check labs to know the functioning of the liver or kidneys. So I'd have to know the GFR. That's
And your EHR will have one, so we'll show you. Don't worry about the working the computer when you're in here. We'll show you how to find everything. It's just knowing. It's just you knowing that you need to find it.
okay.
So when you ask us, we'll go click here, and there it is.
Okay.
Also, knowing for the indication. So when you're giving it in the clinical setting and you're getting ready to give any type of antibiotic, you want to look in micromedics at the indication for what it's treating, and is that the normal dosage range for that indication?
Why? Like what condition they have that necessitates this med?
Mhm.
Why you're doing it?
Yeah. And sometimes you're giving, like for vancomycin, you'll be giving 1 gram for this condition, 2 grams for this condition. So it's kind of like looking at the safe dosage range for the indication of why the patient's getting it.
Okay. So that's the purpose
Mhm.
why I'm doing that. Now I know.
Okay.
Right. So then I come into the room and I knock. Hi, my name is Eric. I'm a Palomar nursing student. How are you doing today?
All right.
Okay, I'm going to provide privacy. Okay, can you please tell me your first and last name?
Jane Tripp,
Okay, that Jane Tripp on the band. I have it on my MAR. Can you tell me your date of birth, Miss Tripp?
10/31/38.
Thank you. Corresponds to the MAR. And look for. It says that you're. Are you allergic to penicillin, Miss Tripp?
I am.
You are. On the computer. Needed to check that before I left the med room. It says that she's allergic to penicillin. should remember that. Okay, Miss Tripp, today the doctor has ordered some Ancef. It's an antibiotic for you. Have you had this medication before?
I don't know, they just hang a bunch of stuff all the time. They're in here all night long.
Well, let me figure out what they hung up. So this would be Ancef. It was empty. There is no label on the empty bag. For when it was hung, I should know that. So I'd have to look on the computer to see when it was last hung, which I did when I was in the med room. But I come in, double check because it doesn't hurt. It's empty, and I check that. I have to check the primary solution, and this was hung 3/7/19.
How long's it good for?
24 hours. This is terrible. This is not good. This is well beyond 24 hours. So in this situation, it's been hanging for a week. I would have to get rid of this bag and get another bag of normal saline, which is what I will do. So, want me to take it down?
Nope, you did it now.
Okay.
New
So
bag.
now I got a new bag. Everything is good. And what I'm gonna do is I have a label. And I'm gonna tear this guy in half, and I'm gonna put today's date, which is the 14th. We'll say today's the 14th.
I think it is.
And the time right now is 2:45, and I'm gonna initial EF for myself. I'm gonna stick it right on there.
So those labels are just for tubing. So in the clinical setting, they want you to grab, they've got like little just envelope labels, small ones. You would just grab those and stick it on the bag and just date time and initial. That's just for the tubing.
Okay, we just discussed this half hour ago with the instructor who knew this too, and I did the same thing. So I'll get the right tab for future use. So now that I have a new primary line and I'm going to be administering this antibiotic through a previously used line, first thing I want to do is I want to flush my patient's line, and I'm going to be using the distal, proximal, this is medial. Medial is used for TPN, so I don't want to do that. So I'm gonna flush the proximal line. I'm gonna raise this so I can save my back, so I can work for 35 years and keep it at a nice safe level. How are you doing, Miss Tripp?
I'm alright.
You're okay? Alright, I'm gonna flush your line. So I'm gonna do my clean. I don't need gloves. So I'm gonna clean that.
For how long?
15 seconds and then wait for it to be dry.
I would do that. So when you're practicing, don't shortcut, don't shortchange yourself, because you're gonna find yourself in the clinical setting going 15, done.
Okay.
Right, so really practice using 15 seconds.
Okay. So I will clean that for 15 seconds. I'm gonna keep it up. And these are all locked. The the clamps are all locked in all of them, including the one I'm gonna be injecting the saline.
Wait. So now hold up your syringe. What's in there?
Saline.
What else?
Air. Oh, I'm gonna
Hold back first.
pull back because yeah, now it's coming back to me. Okay. Is it okay if a little bit of that drips out?
Oh, yeah.
Okay.
Yeah,
All
that's
right.
fine.
So
You
now
wanna make sure there's no air in there. You don't wanna be injecting air right into the central line. Yeah.
I do not.
No.
So once I have that and I have the air in there,
It's gonna be down 2 minutes. It'll be in normal one, I think.
and then I'm gonna do.
Can I have the syringe real quick?
There you go.
Because I wanna have you be able to do it, but you can't really put that in there.
Now, if that happened,
If it touched anything, you'd be getting a new one and rewiping.
yeah, but nothing did. It's really dexterous. Alright, so now once I have that connected, I'm gonna open up the clamp. And then I'm gonna do a push pause to assess for any occlusion, and I want to do a push pause method to create turbulence in the right atrium to. That's a bad answer. Yeah, I'm gonna do push pause assess for occlusion.
Do you have to push pause to assess for occlusion, or would just pushing assess for occlusion?
No, I want to push pause because if I'm doing that, then I'm gonna feel if there's resistance. I don't want to just jam fluid in there.
But if you're pushing in with one smooth motion and there's an occlusion, you're not going to be able to go anywhere anyway, right? So there's a different rationale for the push pause is what I'm getting
And I have no idea.
at. Okay?
So you're getting rid of any clot at the bottom, or at the
That cap.
Hopefully there isn't one, but you want to prevent it, right?
Yeah.
Anybody else?
You want it to
It
like
does.
swirl.
What's that?
You want it to swirl in there.
So you were right with creating the turbulence. You want it to swirl, but within the line, not in the right atrium, but
Yeah.
that would irritate the atrium.
Okay.
But you're just trying to clean out that line and make sure no medication is sticking to the sides or any fibrinogens are building up. So that good flushing technique helps prevent the fibrin cloth, fibrin sheath, or occlusions.
It's turbulence in the line, not the H, right?
Yeah, because it's cleaning it out.
Okay.
Kind of like a rotary disk.
So that's one rationale for it, and the other, well, that's the rationale. I'm thinking too much.
Yep.
Okay, so that's what I'm gonna do, and then there is no resistance, so I'm gonna insert the fluid.
Were you still push pausing?
I push pause in the beginning, and
Push
then
pause the whole way through because you want to keep that cleaned out and make sure that no.
this is where I'm getting confused. Okay, so I'm gonna push pause throughout the infusion of the normal saline, and then once I empty the saline, then I'm going to lock this
And why are you keeping positive pressure? Why are you keeping the syringe?
so that no air is getting in there.
Where would the air come from?
Or it's positive pressure
Mhm.
to ensure that this, just to ensure that there will be no air.
Where would air come from?
Air wouldn't come from anywhere. I don't know.
To prevent backflow.
Yeah, so
Backflow.
you've cleaned out the lumen of that catheter, and now when you're done, if you keep positive pressure, it prevents blood from coming up into the tip of that catheter and clotting it off.
Okay, okay, now we know. Okay, so once I have that, I'll throw this in a sharps
You have a sharps there for
container
you.
that was within my field of, or within reach. My patient's bed is elevated, but it's not out of my field of vision. And so once I have my patient, there's patency in her central line, I can spike this
What do
bag.
you want to do first?
Um,
It really should be done after you scan the patient and check the patient.
I didn't mean motion scanning,
Your next thing is to scan your med.
okay,
So you gotta do the rights in the room
okay,
as your fourth check. When's your first check?
in the med room. Or checking the doctor's
The
orders.
doctor's order?
And then in the med room, and then the third one is in the patient's room.
And oftentimes we do 4, right? So we're checking the doctor's order, then we go in to gather the med, we pull it from the Pyxis, we check it then we check it against the MAR, and then we go in the room and check it again. So
Okay,
it's really 4.
yeah, that's what we've been doing this whole program. Okay, so before spiking the bag, I'm gonna check on the MAR medication, and I have 1 gram in 100 milliliters of Ansef. I have it on my MAR. This is for Jane Tripp. I have Jane Tripp. I have the expiration date. It's November 19th, or 2019. It's clear, an unopened bag, and I think that's it. And it's for a central line route, and it was at 2:30. It's 2:45 now, and I wanna check, I wanna make sure that this is locked, make sure all my lines are locked. This one's gonna come through here, so I want this locked. I need practice. And I wanna check the time that this, tubing was used, cause it's good for, I'd have to look at the hospital protocol.
Today it's good for 7 days.
Okay, so this previously used tubing is still okay, and I have that locked, I have my primary line locked, and then I can take this back down. Actually, what I wanna do is I wanna purge this line of any, excess residual med.
How do you want to hold the bag?
I wanna invert this, but I wanna open up all the lines.
They're already open.
Okay.
Well,
Not this one,
not that one.
because
Well, what's happening in your drip chamber right now?
well,
So I'd wait to open up your secondary clamp, wait until you're ready to start the purging, because you opened it and then you were looking all over here, and in the meantime, it's back flushing.
okay, cause it's coming through there. So once I have it lowered below this bag, it'll drain the gravity, then I can open this clamp. So I'll do this.
And that's plenty. You really just need a line of fluid across the bottom of the bag. But it's only 10 milliliters that you're washing out on that secondary.
Okay.
Yeah,
So
so it
this
doesn't
is
take a whole lot
Okay.
more than.
Okay. So once I have the secondary line purged, then I can take this out. That will have gone, that can just go in the trash.
As long as there's no patient identifiers.
Okay. So once I have that, because this is compatible with this med, I can open this line just to fill up this chamber.
What do you guys think about that? Why not?
That's-
You would want to put the medicine in there.
Yeah, so
So
you
flip
just
it.
you'd wanna flip it and hang
Yeah.
it, so that it's the higher one. And then you'd
Mhm.
squeeze the chamber, I
Yeah.
believe.
You don't need to squeeze the chamber even because it's already full, right? So you
Because
don't want to
purged it.
dilute the medication in the bag. You purged it into the old bag,
Uh-huh.
right? And then you spiked the new bag, then you just hang the new bag up. Because you don't want to be putting out normal saline into the new bag because you're diluting the medication even further.
And
Okay.
you already primed the tubing, so you don't need to worry about that.
So because I already primed it into the old medicine bag, I don't wanna put any more primary solution in that bag.
Right.
Okay.
Because the purpose of back flushing is just to clean out the old medicine from the tubing.
Okay. Okay, so, once I've done that, then I'm gonna put today's date, the time I hung it, so 3/14/245 in my initials, and then I'm gonna,
You love those stickers.
I know,
Just a white label usually.
yeah. I need to get in the habit of, getting the right one. So once that's hung, then I'm gonna program into the connect. I wanna make sure that this whole line is, yeah, I'm drawing a blank now. I wanna connect this to the port that I already flushed, but I wanna ensure that there's no air in here. So
It is there.
this is clamped, so then I can open this and drain this into a waste bucket to make sure that there's no,
Well, you can look at it visually to see if there's no air, right?
there is air, right there. There's no air, oh, and there's air up through here.
Yeah.
And this is open, so I have to do that. practice. I think I know how to do it. Okay, so I'm gonna take off this.
Wouldn't that technically be part of earlier? Well, when he noticed that the bag was hanging for a week, wouldn't he have changed all of the tubing?
If the bag was hanging a week, yeah, if it had just expired, you would just change the bag, not all the tubing, but
Okay,
if the bag was hanging there for a whole week, I would change the tubing too.
so then if I wanna change the tubing, then I wouldn't be doing what I'm doing right now.
No, but it's good to troubleshoot, so how are you gonna get rid of that? You did see air there,
Yeah, so I'm gonna open up this clamp.
and nothing flows, why?
Nothing flows because there's a kink in this.
So when it's in, the reason we can have you open up all the clamps, and it won't run, is because when the pump is off, it's clamped in the pump.
So I have to open up this clamp.
Now, are we gonna have you go through this during skills testing? No, we would verbalize, we'd want you to state if you see air in there, but then you would say, okay, do you want me to actually purge it, or can we say it's done? We'll say it's done.
Okay, we'll say it's done.
You wanna do it for practice? Do you know how to do it?
Might as well, I'm already knee deep into this. I don't know if I'm doing this right at all.
So now that it's clamped there, so you just have to squeeze that clamp. There you go.
Okay.
And just follow the air, the last air bubble out.
Well, for the sake of this, we'll just say there's no, well,
There's quite a bit of air in there.
there's a lot of air. So no, there's no air. I think I can just clamp this. And
Just put it back in the machine, it'll come out for you.
hasn't touched anything. I'm gonna connect it to this port, the proximal port. That,
For how long?
I'm gonna clean this for 15 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. And I won't put trash on my patient.
And then be careful you're not tugging
Oh,
as you flush and as you connect, you don't wanna tug on that central one.
okay. So once that's opened, I have, well, I don't wanna get fluid in there, I'm gonna open this.
You can
This is-
open it, remember it's clamped while it's in the pump.
That's right, so this I can open, this I won't, but I would.
When would you open it?
I would program my machine first and then open this because it won't start infusing because it'll know that this is it's occluded on this end.
It's secluded in the pump, so you can open all your clamps when you're ready, but what are you gonna program first into the pump?
I'm gonna program the drug I'm administering,
What do
which
you
is
wanna program first?
the infusion rate of the drug.
Before that? You asked for this.
I what?
You asked for this.
Yeah, I did, and I'm regretting every second of it, but I'm glad it's now. I don't know.
Primary first with the
Primary first.
TKO.
Yeah,
So
so the
just-
flush, cause it needs to flush in, it needs to flush after. So you wanna always program your primary first and then your secondary. Cause then once the secondary's done, your primary will kick in,
Okay, so all I do is program the primary as TKO.
which is
Okay.
what? What
To
would be the
keep-
rate?
That I don't know.
10 to 20.
10 to 20 an hour?
20 for central. It can be 10 to 20 for peripheral, but 20 for central.
Okay,
So I just always remember 20. Just do 20 either way.
you're safe 20 peripheral or central?
Mhm.
Okay, so I would program the primary line to 20 milliliters an hour. And once that is set, then I would program the ANSEF for 133 milliliters.
What
and,
volume would you put in for the primary? The flush bag.
um,
So 20 mLs an hour.
this is 1,000.
Do you want the patient to get all of that?
No, I don't. So
There's no absolute right or wrong to this, but I usually just do 20 and 20. Because then once the ANSEF is completed, that will kick in and it will flush in your medication. And you don't want to leave her hooked up, but you might be distracted or have to do something else with another patient. So it might take you a while to get back in to disconnect. So that gives you an hour before the pump starts beeping
Oh,
and it's
buffer
flushing
zone.
in the med.
okay, that's what I would do.
Okay.
Now that she's hooked up, I will lower the bed.
Wait, we just programmed the primary.
Didn't I program the ANSEF?
So what are you gonna program the ANSEF for?
133 an hour
And what volume?
at 100 milliliters.
Okay, then what are you gonna do once you hit start?
She has had this before. It's what was hanging before, but I can stay here for a few minutes just to make sure there, by some freak chance, there was an air bubble that got in there, and she didn't have any difficulty breathing. Make sure that the drug is infusing and there's no complications.
It's not infusing.
It's not infusing?
How do you know it's infusing?
This would have to be open.
Yes. Go ahead, open it.
Is it gonna get, no, 'cause that's clamped. Again, we're repeating that.
And then the pump is beeping now, downward occlusion.
Downward occlusion, so that would mean that, this or this was clamped, or there's a kink, or maybe, she was leaning on it. Or maybe in fact I didn't screw this in if it was,
Is it unclamped? That side?
Yeah.
Okay,
is that,
good, I just didn't see
is
that.
my rationalization
Yes,
correct?
perfect.
Okay.
Okay, now it's going.
So now it's going, and the patient doesn't have any adverse reactions to the medicine. I'll give her the call light, and okay, Ms. Tripp, I have your ANSEF infusing. It's going to infuse and to check you out by. I shouldn't make any promises. I'll be in to check on you. Do you have any questions for me?
Nope.
Okay, there's your call light. If you need anything, go ahead and hit that button. And then, once I'm done, then I'll, I didn't, which is something I should have. Should have checked, should have palpated for any pain. Ask her if she's feeling any pain. Look for signs of redness, any swelling, any noticeable discharge through the patch.
Yeah, so always start at your patient and then work your way up.
Okay.
So assessing the IV always before you spike the med, because what if there was something wrong with it? Then you spike the med and you can't use it again, so.
Assess my
Always
patient
assess
first.
Yeah.
Okay.
And in here, just feedback that, when you do the flush, have your line ready on the bed next to you. Do the flush, push pause, push pause, push pause, disconnect, and then hook up the line right away. Then it saves steps, right? Then you don't have to go back and clean it again and hook it up, later.
So this line, just so I don't leak it anywhere.
It's not gonna leak. It's in the
Okay.
pump.
Yeah, I don't know why I can't remember that. So this was hanging up, and it has the sterile cap on there, and I'm ready to flush the port. Then I can take this down, take this line down, make a mess of it. Take the cap off, throw the cap away. This is sterile because it has a sterile cap. But hold this up like this. Take this port, clean it for 15 seconds, push pause, and then flush the line, and then sharps. So I have to locate the sharps before I come in the room. And then
If it's not right there, because a lot of times the sharps are on the wall behind the bathroom door, you can set it right on top of there or on the bedside table and then throw the sharps later.
that's fine. Okay.
And the less you have in your hands, to me, like when you're learning the skill, the less you have to be holding on to, the better. So you can play, can you put the sterile cap on it? You wouldn't do that. It's pretend it's sterile.
Yeah.
Okay. If you just lay it next to her, that way you have your hands free to do the cleaning and the push pause. Leave the syringe attached, right? Let go. Then you can pick up that and then disconnect and connect. That way you're not
Like
trying
that?
to hold on to that while you're flushing the line and everything.
Okay.
It just saves steps. It's not that you did it wrong, it just
No,
it's
I
quicker
just-
that way. And you almost forgot to hook her up, so it's
Yeah,
nice to do it all at once.
yeah, and to be watched puts it a whole nother spin on it.
By how many eyes?
Yeah, well, this was horrible. I can't wait to watch the video.
Got 40 minutes?
How long was that? 30 minutes?
I'm at 33, but I started like 3 minutes late.
Damn. Sorry. I've been practicing.